Dr. Hashmath, who is a palliative care physician. She did her basic certificate course in pain and palliative medicine, and after that, she did her fellowship in palliative care medicine from Institute of Palliative Medicine. Then she did her foundation course, online foundation course with us. She has 2 years of experience, and now she is in charge of our telemedicine department. She is a well-versed person in this field. And welcome and over to you, ma'am.
Thank you, Sister Sheba, for the introduction. So the topic for today is going to be Introduction to Pain. So just a moment, I'll share the screen from my end. I hope you all can see the slides. Okay. Is it clear for all of you? So yes, so we will proceed with today's session on Introduction to Pain. So what is pain? Pain has got different ways of expressions. I think you people will all remember. For example, just consider you going to the work in the early morning, and on a particular day you got headache, and then all of a sudden you feel so irritated, frustrated. You are a person who is very dedicated to work, does everything very correctly, and all of a sudden what happens is, because of this headache, you're not able to tolerate, not able to work and function properly. And on that particular day, you just messed up your work, and some of your seniors just came and they shouted at you, telling that you have not done anything well today. So, how do you feel at that moment? Sometimes certain people may burst out in cry, and they may cry a lot. Sometimes people go into a state of anger, and that is why I say pain has got different ways of expressions. Just remember your mother while she delivered you. The labor pain that she underwent was very pleasant for her because she gave birth to you. So the way of expression at that point is different. So pain is something which expresses a lot of emotions and holds a lot of emotions within it. So, pain is a subjective experience. It is perceived by the person. And International Association for the Study of Pain says that it is an unpleasant sensory and emotional experience. See, it is a sensory, but at the same time, it is something which is very emotional, which is associated with or resembling that associated with actual or potential tissue damage. So, this was the definition given by IASP, and Robert Twycross says that pain is what the patient says hurts. I would always go with this definition for pain because it is very easy to understand that when when a patient says that it hurts him or her, then that is pain. So, what are your thoughts about total pain? Have you ever heard this word total pain? And what are your thoughts about it? Can you put in the chat, or if you can unmute and answer, it would be so good. Have you ever heard the word total pain? So, Divakar says total pain is a scale of 1 to 10. Okay. Any other answers? What do you mean by the word total pain in palliative care? Whatever just random comes into your thoughts, you can just put it in the chat because we are going to learn about pain.
Uncontrollable pain.
Okay, uncontrollable pain. Any other suggestions or comments on total pain? Physical, emotional, social, and spiritual. Yes, very correct. By Sylvester. Oh my God, Sylvester is here. Nice to see you, Sylvester. Hi. So we did our fellowship in palliative care together, and we recently met at Calicut in November. I hope Sister Sheba also recognizes him. So thank you, Sylvester, for joining. And the other person, Aris Kendall, he says involves other dimensions aside from physical pain. Okay, so you have put a lot of comments. So we'll go with what Sylvester said, that is physical, emotional, social, and spiritual comprises total pain. So to go further, we will take this scenario, which is to be kept in mind for all of you for discussion at the end. So I want you all to take a picture of this, and for I'll read out this scenario for all of you right now, and then we will move into the discussion further. So Mr. Yogesh is a 45-year-old male who lives in a small village, which is about 25 to 30 kilometers from your city, that has a PHC. PHC is a primary health center. Okay, so he worked as a carpenter and he was the only breadwinner and was a chronic smoker and alcoholic. This had previously caused a lot of conflict in the house because he was an alcoholic and a smoker, and he was a primary breadwinner. That has led to a lot of conflict in his house, and he has two children, the elder daughter who is 15 years old and the younger daughter who is 10 years old. 8 months earlier, he was diagnosed with a squamous cell carcinoma of his left cheek. So he has a cancer in his left cheek. So poor financial status prevented him from undergoing treatment because he is very poor, doesn't have a lot of finance to go and take treatments properly. So it prevented him from undergoing treatment. He now has a large, irregular, and foul smelling ulcer on his left cheek with a oreocutaneous fistula. So he has a large, foul smelling ulcer which is there in the left cheek because of the cancer, and it also has oreocutaneous fistula and, communicates with the outside. He is in severe pain and is unable to sleep, eat, or drink. Okay, his wife is refusing to care for him, and relatives do not visit him. Doctor from the nearby primary health center has provided tap tramadol 50 milligrams BD for 2 days back for pain, but that is inadequate pain relief. The hospital that he visits does not have access to tab morphine. Dressing of the wound is done only when Mr. Yogesh can travel by bus to the hospital and only when his wife agrees to accompany him. Clear? So just take a snapshot of this scenario, keep it in your mind. We are going to discuss about this in detail. It may seem to be ABC for you as of now, but once we finish with the session, I think you will be able to answer whatever you have in mind. So just keep this and we will move forward. So the concept of total pain was introduced by Dame Cicely Saunders. So she was an English nurse who introduced the concept of total pain, later turned into a physician, was a palliative care physician, and had done a lot to the field of palliative care. So, according to the total pain concept, pain is not just a physical experience. So, pain is something which is not just physical. As I said in the beginning, pain creates an emotional response within every individual. It also has a social impact, and it also creates a spiritual meaning. And all these dimensions, that is the emotional, psychosocial, as well as the spiritual, will either have a positive or negative impact on a person's pain. And it will alter. Okay, so it will alter the pain perception a lot. So we need to always remember that pain causes more pain and all pains are real. This statement was told by Dr. M.R. Rajagopal to me when I joined Pallium, because many times initially when I entered into the field of palliative care, I have often wondered why this is happening, what is total pain and all of it. So he always tells me pain causes more pain. So, and all pains were real. It doesn't mean that only physical pain is real and emotional pain, social and spiritual pain, whatever the patient experiences is not real or unreal. It means that the total pain, the four dimensions of pain are all real, and we need to understand that. So this is a detailed explanation of the concept of total pain. So physical pain is because of the other symptoms, especially pain, insomnia, sleeplessness, anorexia. Most of the cancer patients will not be able to sleep properly, will have a chronic fatigue, will not take food properly. So all these physical symptoms that lead to pain will come under the physical part. And the psychological. Think about a person who got carcinoma and has been, like, went to n number of investigations and walked into n number of hospitals to find out a primary diagnosis that so and so patient has got cancer. This happens in every sitting, right? You would have seen many patients who came to you after 12 months and saying that initially it was just a gastritis. The doctor told it's a gastritis, and then we evaluated. We went into 3 to 4 hospitals, and later it was diagnosed after 6 to 7 months that it is a carcinoma. So think about the anger the patient as well as the family will have because of the delay in diagnosis and also because of the therapeutic failure. For example, in cancer, we go for surgery, chemotherapy, radiotherapy, so many aspects have come, hormonal therapies have come. But just think, if there is a failure in the therapeutics that has been used, think about the anger the patient as well as the family will have. And also the disfigurement. You can just relate to the scenario that I had posted before. Can you imagine a person with a large ulcer in his left cheek with contents being oozing out from the ourocutaneous fistula and a lot of disfigurement in the face because of that ulcer in the cheek? So this will lead to psychological depression. Sometimes patients may even have clinical depression and will attempt go for suicide and all that. And also the fear of pain and death. Think about how the people will feel when, when they get a life limiting diagnosis like cancer. They will have n number of questions within themselves, like how is it going to be further? Will I have a lot of pain? Will I die? Will I have a very bad quality of life when I die? Will there be no one to take care of me when I die? So all these aspects will lead to psychological pain. And think about the social aspect. You just imagine the same scenario which I had told previously, where the patient is the primary breadwinner of the family, is a carpenter, and now he has a large, ulcer in the left cheek. Will he be able to go to work on a daily basis with such an ulcer, with such, a severe pain and all these symptoms not being managed adequately? Will he be able to go and take care of the family properly? What will happen to the family's finance? And what will happen to the children? He had two daughters who were at school. So what will happen to their education? And also the loss of job. He will lose the job. Many other institutions might not hire him, and he will lose his income as well as prestige in the family, as well as loss of social position and role in the family. And many times, when people have this foul smelling ulcer and all, the relatives or even the family members, they feel, they don't get near to him, or they just abandon him, keep him under isolation. And all this will create emotional as well as social pain for that particular patient. Spiritual dimension is totally different when a person starts questioning himself, like, what has happened to me? Why did this happen to me? I did not do anything wrong, but why did this happen to me? Even we, right, when we are getting something, when we fall sick, we have often felt, why this happened to me? Why does God allow me to suffer like this? So spiritual can always be cannot always be only in terms of religious aspects, because the dimension is totally different for different people. For a religious person, might be spiritual would mean something which relates to the religion, but for someone who is an atheist, who doesn't pray or who doesn't have a lot of connection with God, the spiritual meaning is totally different. What is the point of continuing in my life with all these suffering? Is there any meaning or purpose in my life? Why am I alive right now? And can I be forgiven for the past, something I have done wrong in the past? And will I be forgiven for that? When I die, will God forgive all this? So there are different aspects to spiritual dimensions, but this is how James Cicely Saunders defines total pain together. I hope you all can understand whatever I am talking right now. Clear? So moving forward, there are certain factors which affect the pain perception a lot. So the pain is increased when there is anger, when the person has fear, has a lot of anxiety, and has depression and discomfort. Every day he has discomfort because of the pain, because of many other symptoms like breathlessness, like constipation, urinary retention. All this will lead to discomfort. Whatever symptom which causes discomfort for the patient is going to increase the pain. And also grief and other symptoms like whatever I said, vomiting, breathlessness, sleeplessness, lack of understanding about the disease. Just imagine in a country like India, where collusion is very, very common. I hope you understand the meaning of the word collusion. I'll just explain with an example. Many times when a patient comes with a life-limiting illness like cancer to our outpatient unit or to our inpatient unit, you could have come across a scenario where the family members initially jump and come inside the OP room to talk to the doctor and the nurse separately, saying that my father doesn't know the diagnosis. Kindly do not tell him anything about the disease. We are told that he has some other condition, just a gastritis. For a person who has a esophageal carcinoma, many times the family members might say he has gastritis, and they would hide the diagnosis as well as the prognosis of that particular disease with the patient. So that is something where the patient lacks understanding about the disease, and he starts thinking every day, every night, he starts questioning himself within, what is happening to me? What is happening to me? All these factors will increase the pain. The term that I told you, right? The collusion, that is what happens everywhere in India. Most of the Western cultures are completely different where wherever if you go to UK, obviously if a patient is more than 18 plus and comes with a life limiting diagnosis, you don't need to go and talk to the family members. You can go straight, sit with them and say that this is a diagnosis. But that doesn't happen in a state like India where collusion is present and people hide these diagnoses as well as the prognosis with the patient because of the factor that we are very much bonded to them. As Indian culture, if you see most of the other cultures also, families are very much bonded, so much loving that they don't want the other person to suffer after hearing that so and so patient has such a diagnosis. So, lack of understanding about the disease will increase the pain. And also, mental isolation, abandonment, social abandonment, all these things will increase the pain. But at the same time, when you see the other box, you can see that when there is an acceptance, pain decreases. When the person starts to accept that this is the diagnosis he has and this is how it is going to be. Initially, for a short period of time, he might feel very upset. It will take time for him to process that and, get back to normalcy. So pain gets decreased when there is acceptance, when there is reduction in the level of anxiety, and when there is relaxation, when there are any diversion or distraction techniques that are followed, and when a person starts venting his feelings. Usually, as a palliative care people, I think you would have seen a lot of patients who, when you spend time with them, they start speaking a lot, they vent out their feelings, and at a point, they feel so relaxed because they have told everything to you. You have given them the time to speak out. So, venting the feelings plays a major role. And relief from other symptoms. As I said, pain increases when there is urinary retention, when there is constipation, when there is breathlessness, insomnia, and all that. It gets decreased when you properly manage the other symptoms also. And when the person gets a good sleep, when he gets an explanation for why he is suffering, obviously pain gets decreased. So these are the different factors which affect the pain perception. So moving into the pathophysiology of pain, when there is a local injury, for example, just imagine a pinprick in your finger. What happens is there will be release of inflammatory mediators. These inflammatory mediators are bradykinin, histamine, as well as prostaglandin. What does this do? It will stimulate the nociceptors, which are the peripheral sensitization receptors, which are present peripherally. And the pain impulses from the peripheral receptors are carried to the dorsal horn of the spinal cord. The dorsal horn of the spinal cord is the place where there is a primary relay. And from the dorsal horn of the spinal cord, the impulses reach the thalamus. So initially, there was a nociceptor here peripherally. It takes the pain impulses to the dorsal horn of the spinal cord, And from there, this impulses reach the thalamus via a tract called the spinothalamic tract. And this is where the secondary relay happens. And from there, from the thalamus to the cerebral cortex is the tertiary relay, and from the cerebral cortex to the limbic system. So this is how pathophysiology of pain occurs, and that is why I have put this picture where you can see the nociceptors are there peripherally, and you have the afferent nerve fiber which takes the impulses to the dorsal horn of the spinal cord, and from there it takes to the just a moment. Okay. So from the dorsal horn of the spinal cord, you can see that it is being taken to the thalamus, and from there to the from the thalamus to the cerebral cortex as well as the limbic system. So this second order neuron, whatever you see, is the spinothalamic tract, which carries the sensation from the primary relay to the secondary relay. So there are many other relay centers for pain in the brain. You know that brain has different lobes, like parietal lobe, temporal lobe, occipital lobe, frontal lobe. So the sensory areas of the parietal lobe are responsible for the localization as well as the interpretation of pain. And the limbic system is responsible for the emotional as well as the autonomic response to pain. And the temporal lobe is responsible for the pain memory. It just holds the memory of what pain you have. That is when we speak to patients, we often ask them, is this the same pain you had 2 weeks ago, or is this something which is a new pain that has occurred for you? Because they are able to remember it, because the temporal lobe plays a major role in that, and they are able to say, no, ma'am, this is the same pain which I had 2 weeks ago, and it has come now again at a severe intensity. Or sometimes they may say, no, this is not that pricking component of pain which I had previously, but this is something other which had happened recently for me in the past 2 days. So the temporal lobe plays a major role in the pain memory, and also the frontal lobe plays a major role in the pain behavior. So there are different types of pain. So initially, to talk about nociceptive pain as well as neuropathic pain, which is very, very important. Nociceptive pain is the pain sensation which is resulting from injury to the tissues. Whatever happens to the tissues will result in the nociceptive pain. Usually it is termed as throbbing, aching. All these types of pain will come under the nociceptive pain. And here, what happens is you can divide nociceptive pain into two components, that is the somatic as well as visceral. Whenever we say somatic, it refers to the soft tissue as well as bone. And whenever we say visceral, it is the hollow organs like the capsular part of the organ, or can be the bowel, or can be the cardiac part. So these are some things which come under the visceral. So here in nociceptive pain, there is stimulation of the peripheral nerve endings. And what happens in nociceptive pain is that the sensory nerves which are present in the somatic as well as the visceral components are functioning normally when the person has a nociceptive pain, which is totally different from in case of a neuropathic pain, where the sensory nerves, that is the somatic and the visceral nerves, are functioning abnormally. And this neuropathic pain is mainly due to an injury to the nerve, or it is due to the nerve compression. It is defined as the pain which is initiated or which is caused by a primary lesion or dysfunction in the nervous system. Many of the books term it this way, that neuropathic pain is something which is initiated and which is caused by a primary lesion or dysfunction of the nervous system. And neuropathic pain is usually burning, pinpricking, lancinating, stabbing. So patients will term it this way whenever they have a neuropathic pain. And most of the neuropathic pains have a radiating component too. Like for example, in a person with sciatica, I think you would have heard about it. When the sciatic nerve gets injured, the sciatic nerve is the one that supplies the lower part of the lower limbs, that is the thigh as well as the legs. So what happens when there is a sciatica? There is going to be a nerve compression at the level of the sciatic nerve, and the person will have some tingling feeling. Sometimes they may have some, a kind of whatever I said, a burning type of pain or a stabbing type of pain, which is really very irritating to handle. So, which is also radiating right from the lower buttock region to the legs. as well as to the ankle and foot. So that is how neuropathic pain usually presents. I'm just giving an example for kind of neuropathic pain. And this is a classification of pain, whatever I have talked previously. Like nociceptive also has physiological as well as pathological reasons, as well as neuropathic. As I said, it can be due to nerve compression, which is functional, and also can be a nerve injury. For example, think about a person with stroke. Post-stroke, many patients experience pain because they have the central spinal cord which is getting affected because of the stroke, and they will have severe neuropathic pain. They might have, if they have a plegia and they don't have sensations or weakness in the bilateral lower limbs or in one side of the upper limb and lower limb, obviously they may report you with a lot of neuropathic features, like they will have radiating kind of pain, a burning kind of pain, a kind of numbness, a kind of tingling sensation. All these will come under neuropathic pain. And also in terms of, a peripheral neuropathy, most commonly the peripheral neuropathy that we see in clinical settings is a diabetic peripheral neuropathy. Many patients with diabetes, that too, they have if they have diabetes for so long, like for many years, they will present you with a tingling and burning sensation in the bilateral feet, especially during the night, which is a very common feature of a neuropathic pain which happens peripherally, and it's very common in diabetic neuropathic cases. And also in post-herpetic neuralgia, whenever there is a viral infection, that's a herpes zoster or a herpes simplex, most commonly these patients will present with neuropathic pain because only one part of the nerve gets involved, because the lesion has happened only at that part, and the patient will present to you with typical features of neuropathic pain. So these are some of the examples that I wanted to say. And few terms that are very, very important in relation to neuropathic pain as well as a nerve injury pain is allodynia, hyperalgesia. What do you mean by the term allodynia? Do you have ever come across such cases where you have seen patients with allodynia? Have you ever seen such scenarios? Here, usually what happens is it's totally different, where a person has a noxious stimuli which happens without even giving them a painful stimuli. For example, a light touch. Just take a feather, just rub over your skin. Is it going to cause pain for you? Definitely not. The feather touch is not going to create any pain for you. At the same time, the dress that you are wearing. If you put on your dress, do you feel any pain in your body? No, we don't feel it, right? So even this light touch exacerbates pain. That is what we term as allodynia, which is very, very common feature for patients who present with neuropathic pain. And also hyperalgesia. For example, I'm just pinching myself like this, very light manner. A little bit of pain will be there, definitely. But if this small touch, a very not a very light touch, but you're giving some pressure and you're putting in a level of pain, but that is going to create only a mild pain for a normal person. But for a person who has a neuropathic feature and who has a hyperalgesia, will wince with pain, will wince with severe pain when you just go and just pick their skin like this or just hold them like this, which is going to actually cause a very limited pain. So the mild, noxious, painful stimuli becoming more intensively noxious is termed as hyperalgesia. Clear? Can you all understand whatever I'm speaking right now? Because introduction to pain is very, very important. In this chapter, in this part, you will be learning entirely about pain and how to assess and evaluate pain. So I hope if you have any doubts, you can put it in the chat. When we finish off with the session, we can take these questions. And moreover, if you have any disturbances, not able to hear me, something like that, also you can just put it in the chat. Okay, shall we move forward? Fine. So next is the central sensitization. So what is central sensitization? Just think, I just removed my tooth. I had a bad toothache. I went to the doctor. I had a caries tooth and I removed the tooth. I will have pain there for about a week or maybe for 2 weeks. But if I have the same pain for about 5 months, 6 months or 7 months, what will happen to me? I'll become very upset, right? I'll become very upset, very frustrated, very irritated. So what is central sensitization? When the pain is experienced over a prolonged period of time. So as I said in the pain pathophysiology, we have this peripheral nociceptors which take the pain, peripheral sensation of pain to the upper tract, right? So what happens here is along the peripheral nociceptors, there will be some sleepy nociceptors, which are very sleepy. They are not going to act anyway. But what happens in central sensitization is even the sleepy receptors, which were sleepy previously, have now become activated and they got sensitized, and now they are going to recruit pain. They are going to just produce the pain sensation continuously, and all the adjacent neurons which are next to it also get stimulated, which will result in a recruitment process. So what happens? A person was having pain only because of one nociceptor which is taking the pain sensation. Now n number of sleepy nociceptors which are surrounding it also got sensitized. So what happens to the severity? This person will have the worst imaginable kind of pain in his life, and the wind-up phenomenon mainly occurs because of the NMDA receptors. Okay, so here the patient will have a more widespread pain when there is a central sensitization. Clear? So moving into the different types of pain. We have different types of pain. The baseline pain is the pain which is continuous and intermittent. So usually when you see a patient, when you take a pain history, they might say, you will be asking him whether the pain is continuous or intermittent. So the baseline pain is a pain which is continuous or can be intermittent. And what is breakthrough pain? Breakthrough pain is something which often is a higher intensity pain. It can happen with movement or some weight bearing work that is being done or change in dressing. Like, for example, a patient has pain and has been taking few medications, opioids for pain relief. And all of a sudden, he wants to go to the bathroom. He has pain even at rest, but that is controlled with a tab morphine that you're giving. So now he is moving, he is weight bearing, he is doing some work. All of a sudden, without warning, if there is a pain that is going to occur, it is termed as a breakthrough pain. So it lasts between few seconds to 30 minutes. So breakthrough pain is something which happens without any warning and all of a sudden it occurs. So that is why we often say whenever the patients are on opioids or even other analgesics, can be weak opioids, strong opioids, or NSAIDs, whatever it is, we tell them that if you get a breakthrough pain, like you are taking morphine from morning at 6 o'clock, you're taking one dose, and at 10 o'clock, you will have the next dose. But in between at 8 o'clock, if you're experiencing a pain which is of very high intensity, it is supposed to be a breakthrough pain, and we say that they should take one rescue or SOS dose of extra morphine or extra tramadol. So that is termed as breakthrough pain, which lasts for about few seconds to 30 minutes. So what is incident pain? Incident pain has some precipitating factor for sure. But this breakthrough pain will not have, every person will not have a precipitating factor. It occurs even without warning. So it occurs spontaneously. But here in incident pain, you will have a precipitating factor like movement, for example. That will cause an incident pain. So we often say, like for example, you are going to do a wound dressing for the patient whom I had discussed previously in the beginning. And this patient has not taken any analgesics. Now, if you're going to open the wound and if you're going to do the dressing, obviously it's going to be very painful. So what we say is prior to the procedure, you can give one dose of analgesic and then wait for about half an hour and then do the dressing so that it becomes comfortable for the person. So whenever there is a precipitating factor associated with pain, then for that pain is termed as an incident pain. And what is end of dose pain? It is like, for example, you take one analgesic at 6 o'clock in the morning, the next dose comes at around 10 a.m. But you're getting pain at around 9 a.m. or 9:30 a.m. because the dosage and the duration of action for that particular dose is going to be is getting less. You're going to again give one more dose at around 10, but still pain occurs even prior to it. So that is termed as a prior to scheduled dose. If you are experiencing a pain at the end of the dose, previous dose, then you term it as a end of dose pain. And this lasts until the pain medicine is dosed again. So usually when they present with the end of dose pain, what we do is For example, if they present with the pain at around 9 a.m. and the scheduled dose is at 10 a.m., what we do is we give the dose at around 9 a.m. itself so that the patient's pain settles. So it lasts until the pain medicine is dosed again. I hope you're clear with the different terms that I had told right now, because these different terms are very, very important, and it is very I gave an example because whenever you're seeing a patient, you need to pick up what kind of pain it is. Like whenever you're assessing a patient, you should know, okay, this is incident pain, this is breakthrough pain, this is end of dose pain. So that is why I have told all those with examples. I hope it is clear for all of you. If you have any doubts, don't hesitate to ask me, because we need to clear this out right now. Otherwise, it's going to be difficult while you go and see patients. Any doubts? Shall I move further?
Ma'am, I have one question.
Yes.
Ma'am, incident pain and which one is other? Ma'am, sorry.
Mamta, what you can do is you can just post your question in the chat.
Okay, ma'am.
We can go further and then we can take this question at the end. Clear?
Okay, ma'am. Sure.
Okay?
Yes, ma'am.
Okay. So, what is the difference between acute versus chronic pain? Acute pain is something which is transient as well as which is self-limiting. But chronic pain is something which is persistent, which has a multifactorial, presentation. There are neurochemical changes that are happening and which is unremitting and progressive. It keeps on going. But acute pain intensity reduces with healing. Like for example, post-surgery. Usually at the scar site or at the site where it is being sutured, you will have pain for 2 weeks or 2 to 15 days, you might have pain. But obviously when there is a healing that is happening within, it is going to go. But in terms of chronic pain, it is going to be very progressive. And the other part, acute pain is very positive. It draws our attention and it is protective. When you get a tooth pain, you know that something is happening with your tooth out there and you have to go to the doctor for sure and see what's happening, right? So it is positive. But in case of chronic, it is negative, because when a person experiences chronic pain for so long, it is of no useful purpose for him. It is a constant reminder of a life-threatening disease. Just imagine, as healthcare professionals, we often think when we have a headache, most of the times, when I have a very bad migraine in my life, I had felt that I have some CA, some carcinoma brain. That is why I'm getting this pain, which has been very chronic, which was there for a few days. So it happens with all of us, right? Even for lay persons, even for normal patients, that keeps on, they start questioning themselves, oh, what is happening? Do I have any life-threatening disease within? Is it why I'm having the pain for so long? So it is something which is negative. In acute pain, you will see all these features like pupillary dilatation. These are some of these signs, like you will have increased sweating, tachycardia, tachypnea. This is because there is more shunting of blood from the viscera to the muscles. So you will have all these features. But in terms of chronic pain, you will have sleep disturbances. Person might have depression, personality issues. He or she might be very lethargic. Even if you're speaking, like many a times you would feel like this patient came with, it says that pain score is 10/10 and it's very severe. But while seeing him, I don't think that he has 10/10 pain, because he has chronic pain. He or she might not have all the features of acute pain. So sometimes that might be misleading for many of us, but for chronic pain patients, that is how they present. They present with no pleasure in life. They will have constipation. They will have personality issues. Many times you sit and talk to them, they will be fed up of going to hospitals again and again, explaining their pain. And when they come back to you, and when you ask what is happening to you and all that, they might be very lethargic in answering. So these are some of the features of chronic pain. And in cancer, especially whenever you are assessing pain, keep these 4 things in mind. In cancer, most of the pains can be disease related and can be treatment related, debility related, as well as comorbidities can bring about pain. When there's a disease related, we say there can be soft tissue infiltrations, visceral infiltrations, bone involvement, muscle spasm. When the person has lymphedema, very large lymphedema, which is because of post MRM or some other procedures that's being done, or because of the advanced disease, they are developing lymphedema. Obviously, all these things will lead to might be the cause for disease related things. And treatment related usually because post surgery they will have pain. Chemotherapy, most of the times after chemotherapy they present with very bad symptoms like pain, nausea, vomiting. And radiotherapy, most commonly they present with, after radiotherapy they will have a very bad mucositis and they present with very bad pains to you, and also adhesions because of the surgery which has happened 6 months back. Now there might be any adhesions which is leading to the pain. And debility related, when we say debility related, this patient who is in advanced cancer or is going through cancer might have constipation, might have pressure sores because he or she has become bedridden. There can be bladder spasm, there can be stiff joints because they are not able to move properly, they are already very tired. And most commonly if they are on catheter, like Foley's catheter or something, they might have any infections. All these things which are debility related will also lead to pain. And they might have also other comorbidities, like the same patient having cancer might have a diabetic neuropathy, might have an osteoarthritis or a rheumatoid arthritis, might have some spondylosis, some disc bulge with nerve compression, can have migraines, can become very sick and fall off from the bed, and they might get injured, fall, which is leading to fracture, which can lead to more pain. So these are the 4 general categories that you need to keep in mind whenever you are assessing pain, assessing the causes of pain in cancer. Clear? So moving into pain evaluation. So pain evaluation is a multi-dimensional process, and Robert Whitecross says that multiple concurrent pains are common in one single individual. Only 1/3 of the people might have single pain, and 1/3 may present with 2 pains, or sometimes 1/3 of the population may present with 3 or even more pains at different sites. So it is a multi-dimensional process. So how do we assess pain in palliative care? As I said, now think about the total pain concept, which I told initially to all of you. So whenever you are assessing pain, it is not just the physical that you're going to see. You're going to look into the physical factors. You're going to look into the psychological and emotional factors, the social factors, as well as the spiritual factors. Wherever you go for practice, hereafter, whenever you're going to do an assessment of pain, keep in mind that I am not going to do only the physical component. I am going to assess pain in total. Clear? So for physical pain, you have to have this in mind. O, P, Q, R, S, and T. That is what we say. O stands for onset. P stands for provocating or palliating factors. When we say provocating factor, it is like some factor which is provocating and increasing the pain. When we say palliating factor, some factor for that particular patient, for example, hearing to music can be one palliating factor which is reducing the pain. Like just playing or talking to his grandchildren might be some factor that is reducing the pain. For some people, taking analgesics might be reducing the pain. So it is patient specific and varies from person to person. So you have to keep in mind that O stands for onset of pain, P stands for palliating as well as the provocating factors, Q stands for quality of pain. You should ask the person what is the quality of pain. Many times, like they might not be able to say the exact quality of pain, and they might just say, I have pain. That is totally fine, but you need to ask them what is the quality so that you can pick out whether it is a nociceptive component or it is a neuropathic component. Clear? R. So R stands for radiation of pain. You need to ask the patient, if you have, for example, the patient presents to you with a pain in the abdomen, you need to ask the patient whether this pain radiates to the entire abdomen or is very localized at one particular site. Is it radiating lower down or is it radiating upwards? So radiation factor is something that you need to ask. And S stands for severity. So whenever we assess pain, you have to rate in terms of mild, moderate, and severe. So severity you need to ask to every patient whenever they come to you with pain. And T stands for temporal factors. What do you mean by temporal factors? You need to ask the patient whether there is a diurnal or nocturnal variation in pain. Like you can ask them whether the pain is very worse in the night or in the day. Is there anything that is relating to the diurnal as well as the nocturnal variation? That is what we term as a temporal factor. So to summarize, I have put all that. You need to ask about the site of pain, where is the pain actually? Many times you can just tell them like, just keep one finger and just show me where you have pain. Then they will be able to localize and tell. If they have a localized pain, they will be able to localize and tell you that this is where I have pain. Otherwise, if they have a generalized pain, they will say, no, ma'am, I'm not able to localize my pain. It's there everywhere, or it's there in the entire upper limb. So you need to ask about the site, onset, duration, for how long they have had, how frequent is the pain occurring? Is it continuous? That is what I said. Is it continuous or intermittent? Does it happen early once, or does it present the whole time? Like even during sleep, it is there, 24/7 it is there. Or like when it is intermittent, you need to ask them, how frequent does it occur? Does it happens within 5 to 6 hours once, 3 hours once, hour once? You just ask them, they will be able to say it very clearly. And quality, radiation to other sites, and aggravating and relieving. That is what I termed as provocating and palliating factors. Clear? Then severity of pain and medications. You need to ask them if they had taken any medications for pain, because they came to you with pain. So you need to ask them what are the medications that they had taken previously. Sometimes they might not have taken any medication, but sometimes they might be on any other medications for pain. Then that will let you know, like, okay, already they are on this medication. This is not helpful for them, not given them a satisfactory pain relief. So now we have to move into the next step of the ladder. And impact on the activities of daily living. That is very important. Whenever a person presents with pain, you need to ask them how it has affected the activities of daily living. Like going to the toilet, taking bath. Sometimes people will have severe pain that they might not be able to do the activities of daily living of their own. And also the impact on the person and the associated symptoms. So pain can present with delirium, pain can present with breathlessness, can present with insomnia, can present with anorexia, so many other symptoms, vomiting, and all these can occur. So you need to ask the associated symptoms also. And pain score. Pain scales are very, very important whenever you are assessing pain. So the most commonly used pain scale is the numerical rating scale. That is the numerical pain rating scale. Here, if you have to tell the person that, you need to tell them very clearly that 0, this is a scale of 0 to 10, where 0 mentions that you don't have any pain. If you give a number of 1, 2, and 3, then I take it as you have a mild pain. And it goes gradually increases with every number. If they say 1, they might have a very minimal. 2, though they have a mild pain, it is little bit higher. You understand, right? Like when we say 0 to 10, the pain increases in severity with every number. And you have to tell them that if you give any number from 4, 5, and 6, I would take it as you have a moderate pain. And 7 and something more than 7, then I would take it that you have a very severe pain. So numerical pain rating scales are very, very, very important whenever you are assessing pain. And it is very important that it is subjective. It is not that you are going to mark the pain rating scale for the person. If the person is not able to say, or even if after you gave examples, if they are not able to say the exact score, you are not the right person to score another patient's pain. So they have to tell you the score. So it is very subjective. You have to mention and clearly tell them that this is how we do. And after that, when they give the number, you can write in your notes that the pain score is 5. So I think it is moderate. Clear? So we have other few pain scales like the Wong-Beaker's faces pain rating scale. This is also very subjective. It's not, you have to give this paper to the patient. Most commonly, Wong-Beaker's faces scale is used in elderly. So you can give this and they will be marking the exact smiley that fits them. Clear? So you might be seeing a face where the patient will be in green. Okay. But he or she might be marking something where it is red, like worst pain imaginable. And you shouldn't think that, oh, this patient seems to be so well when I see him, but why did he mark red? Because he is in pain. You need to believe the patient that he or she is in pain. So you shouldn't be judgmental. You should believe the patient and you have to give these scales to them and ask them to mark their pain score. So while assessing pain, that's what I said. You should never be judgmental. Do not assume, never assume that so-and-so patient is saying these many complaints, pain and all this. I think he might have a moderate pain. No, they have to tell you the exact scenario. They have to score their pain and tell them that it is a moderate pain or a severe pain, whatever it is. You need to believe the patient and believe that he or she is in pain. And that is why self-report of pain is the best report. No one can exactly grade the intensity of pain like the person who is experiencing the pain, right? I hope you understand. So this is one more flow chart and tabular form of whatever I had spoken previously. So whenever you are asking frequency, you need to ask whether it is continuous or intermittent, how often in a day and how long does it last, and impact on the activity. As I said, whether it affects your work and activities of daily living, does it affect your sleep? All these are very, very, very important. And medications, you need to ask about what drugs they are taking, what is the route, whether they are taking it as peroral or subcutaneous or intravenous, whatever it is that you have to ask, and how often do you take it? Like you take it 6th hourly or you take it 4th hourly or you take it 8th hourly, whatever it is, that also you need to document. And you need to ask whether it gives a relief. I would say you should ask whether it gives satisfactory relief. That is very, very important. The word satisfactory is very, very important. You just say, like after 2 days, when a patient comes to you pain, you are assessing, you are starting him on some analgesics and then sending him back home, not following up. That is not the right way of doing. After 48 hours is the ideal time to call the patient. Like if the patient is not able to come to your OP or come directly to you, you have to do a call back again to that particular patient and assess his pain over phone and see whether the pain has reduced with the scores. If he says reduced, then you should ask him whether it is satisfactory or still you have pain. Only then you will be able to treat it in a better way. Okay. So how long does the relief last? Like if you are giving tramadol 50 milligram tablet for 8 hours and the patient says that I'm having only 6 hours relief of pain with tramadol and for 2 hours he is going to have pain. So what can you do? You can either increase the dose of tab tramadol to every 6 hourly and SOS and tell them that in between the 6 hours, if you are going to get a breakthrough pain, then please take one extra dose of tramadol, as the maximum dose of tramadol per day is 400 milligrams. Clear? Okay, so how long does the relief last is very, very important. And are there any side effects with respect to opioids, with respect to any medication? We say there are many other side effects with every medication. So whenever you're starting an opioid, you need to know what are the side effects of an opioid. I think in the next coming sessions, you will be having classes on opioids and all of it. So you should be aware of what are the side effects this drug can cause. If you are starting on an NSA, the most common side effect with an NSA is gastritis. If you are not going to give pantoprazole or Gelusil syrup along with that, then the patient is going to have intense burning in his upper abdomen and he will stop taking the medicine. So you need to know what are the side effects that are being reported so that compliance is also ensured. Clear? So this already I have told the OPQRSNT. I have told it in detail. So one more tabular column I have just added. And this is the WHO analgesic ladder for pain. Just understand that whenever you're going to treat pain hereafter, just remember that it should go with the WHO analgesic ladder for pain. So step 1 is the non-opioid plus or minus an adjuvant. And step 2 is going to be a weak opioid plus or minus step 1. That is, you can add non-opioid plus or minus adjuvant. And the step 3 is going to be a strong opioids plus or minus step 1. Okay. So, for example, when we say non-opioids, we have different non-opioids, that is paracetamol, ibuprofen, meloxicam, diclofenac, etoricoxib. All these drugs will come under the step 1 non-opioids. For an example, I would just tell you about paracetamol. Paracetamol is a drug which is a very basic drug. We often term that paracetamol is to be given for fever, and apart from that, we never use it for pain. But paracetamol has very good analgesic properties, and for one particular person, The maximum dose of paracetamol in a day can go up to 4 grams. And how do you calculate the dose of paracetamol? It is usually 10 to 15 milligrams per kg per dose. For example, if a patient is of 60 kg, you are seeing a patient with 60 kg, and you want to like calculate the dose of paracetamol for this patient. So you can multiply it by 10. So he will need a minimum of 600 milligrams, which has to be given every 6 hourly. So you need to give paracetamol every 6 hourly, or you can also give it Q4 hourly if there is no relief with the 6 hourly dose. But the basic is you have to take the weight of the patient and then multiply it and then calculate the dose that is needed and then give it in a proper way, in a cyclical way. Do not miss the cycle. Do not give paracetamol as BD. Do not give paracetamol as TID. It should often be given as Q6H or Q4H. Okay. So you have to give it in a proper time. And every time when you are giving this drug, because mostly nurses, you are going to give the medication in the hand of that particular person. You need to tell them very clearly that, see, Acha, now we have started you on this drug and this has to be taken at this time. Do not delay it and take it properly. And also for the caregivers who are near, you need to tell them and make them understand how this drug has to be given. And in step 2, we have tramadol, codeine, tapentadol, and dihydroxycodeine. So tramadol, the starting dose should be 50 milligrams as TID. That is, you give it 8 hourly. So that is the starting dose for tramadol, and the maximum dose in a day can be 400 milligrams. Why am I saying this? Because as nurses, I want you all to understand that even paracetamol, tramadol, these are very minimal drugs that you are going to use in treating pain. Very common drugs that you're going to use, and you should be aware of what doses that can be given. If your doctor is going to write tramadol as BD, you need to go and tell the doctor, is it okay? Shall we make it TID? It is totally fine to ask them, because you have done this training. Now you people know how to give medications properly. At least I want the nurses to know paracetamol, tramadol, and morphine for that sense. So I just thought of mentioning it. And in case of step 3, we will go with morphine, fentanyl, methadone, buprenorphine, and oxycodone. I think morphine, you will have a separate session for opioids where you will be dealing in detail about it. And for the adjuvants, whenever you give some drug along with this drug, like PPIs, if you're giving NSAIDs, you're going to give PPIs like pantoprazole, omeprazole, rabiprazole for gastritis. And laxatives, whenever your hand is going to write a weak opioid like tramadol or a strong opioid like morphine, then your hand should always write a laxative, that is a Dulcolax, which is bisacodyl, which is a stimulant laxative. And also other adjuvants can be corticosteroids, antiemetics for nausea or vomiting. So these are some other adjuvants. So I'm finishing my session on that aspect. And this is the case-based scenario that we had. And now I want you all to discuss the different aspects of total pain as experienced by Mr. Yogesh. And how will you assess it? Now, I don't want you to write a prescription for this patient. I just want you to say, these are the different factors that come under physical. These are the different symptoms that come under psychological. These are something that can come under social. So I just want you all to type in the chat or just unmute and say that you have identified these symptoms and signs. So after that, we will move with the case presentation. You can put it in the chat. You can take 2 more minutes to read this very clearly. And based on the discussion that we had in the past 1 hour, I think you will be able to find out what are the different components of physical pain that can come in this person. What can be the psychological or the emotional aspect? What can be the social aspect? What can be the spiritual aspect? Anybody, if you want to unmute and answer also, totally fine. You can unmute and answer. Okay, Divakar says socioeconomic poor financial status. Very good. So that will come under the social aspect. Okay. I just want you all to just jot down whatever you have in mind with respect to this case, and that can fit in into all these four aspects. I don't want a very detailed answer or something like that. I just want you people to identify the aspects. Psychological, yes. Wife refuses to care and relative refusing to visit. Yes, very good. Very good, Divakar. What might be the physical? What do you think might be the physical? Cancer pain. Yes. Cancer pain, which is not controlled with drugs. Yes, very good. Belvin, would you like to unmute and answer? I can see that your hand is raised. Pain and foul smell from the ulcer. Yes, very good. Very good, Sister Neeta. Mehboob, would you like to unmute and answer something? I could see that your hand is raised. Socio means uncomfortable bus traveling. Yes, okay. Very good. Yes, he is in total pain. He has headache. Okay. Social stigma. Very, very, very good. Social stigma, because people are avoiding him. They are not coming and meeting him.
False smelling.
Foul smell. Yes, very good, Belvin.
Hello.
Yeah, I can hear you. I can hear you.
Yeah, very good afternoon to everybody. Ma'am, I would like to mention over here that children may not be able to sit along with the father, and
Yeah.
they may be feeling shame to go with him.
Yes.
So we need to create awareness among the family.
Okay, very good, very good. Because he has the ulcer and all this, they might abandon him and they might have the fear to go near him. That's what you mean, right?
Yes, yes, ma'am,
Yes,
yes.
very good, very good. Poor nutrition and hygiene. Yes, very, very good. I could see that you all are coming up with beautiful points. Very good. Any other?
Mamta?
Ma'am, patient has physical pain and psychological pain, social pain also. Because
Okay,
he's very poor.
yeah. He is very poor. He is not able to go for work. Income is lost. Yes, definitely.
And psychological because her wife is not taking care of him.
Yes, very good, Mamta. And Sylvester, I could see that your hand is raised. Can you? Your voice is still mute.
Not audible.
Not audible, Sylvester.
Spiritual also, ma'am. Spiritual patient.
Yes, very good, Anjalakshi. And psychological, Sister Neeta says not able to go to hospital, wife doesn't accompany always. Yes, correct.
And ma'am, patient is taking 50 mg tramadol twice a day.
Okay,
And
okay.
told ki tramadol has 8-hour limit.
Yeah, minimum starting dose should be 150 milligrams. Okay, very good. So he is taking only less dose, and that is not giving him a very good pain relief also. So you need to assess his pain in detail and then talk to your doctor and then plan regarding whether you have to hike the dose or you want to move into the step 3 of the analgesic ladder. That is, you want to go with morphine. All these things you have to decide, right? So yes, now I will just show what are the aspects that I have just noted down. Many of that the you people have mentioned might be missing here, but I have just made a very short thing. So the ulcer, the auricutaneous fistula, which has been there for 8 months, will cause physical pain. The chronic pain, the nerves getting involved here in the cheek, which will lead to neuropathic pain, and also the jawbone gets involved. He might have bone pains, pain on chewing, swallowing, speaking, whatever it is, it's going to cause very bad pain for him. And it's going to be because of the movement. And he has sleeplessness. So insomnia is there, nausea, which you can see in the scenario that he has some nausea, right? So that might be because the doctor started him on tramadol, but did not give him any antiemetic along with tramadol in the initial days that we actually do. And that can lead to nausea. And hunger, think about how it will be. You are eating something and it is going to come out of the fistula. Nothing is going to go in properly. So he might have hunger, thirst, and dry mouth. That can happen. And foul odor, as well as generalized fatigue. And when we move into the psychological aspect, you can see that he is very anxious. He had a prior substance abuse that was there. He was a chronic smoker. He was an alcoholic. Now he is very lonely. Nobody is taking care of him. He would have that guilt and shame on himself. Like, some doctor had mentioned, Mehboob, I think, had mentioned like the daughters might not come and take care of him or go near him. That will create a kind of guilt as well as shame within himself. So that will be some psychological component. And fear of more pain. He might be like, already I'm taking medications, but still my pain is inadequate. Will I have more pain when I'm gonna die? Is this going to be really terrible in future? All these questions will be there. And body image, as I said initially, when he goes and stands in front of the mirror, if he sees himself, he would have become very hectic because he has cancer right now. Anorexia can be there. He can go into hectic phase, and he might be 60 kgs. As a healthy adult, he was around 60 kgs. Right now, he stands in front of the mirror. He could see that he is only about 30 to 35 kgs. His body image is completely gone. And loss of sexual intimacy. You could see that Yogesh is very young. We don't know whether the wife and the husband are able to have a good sexual life, which is not possible because he has a very bad ulcer. Some important aspects that we miss is the sexual intimacy. Many times we just forget that, and we don't even talk to the couple. We don't counsel them to like make them understand and let them know that the wife can feel if she is very uneducated, she doesn't know what is cancer. She might feel that getting near to him might give her cancer. So all these things will add on to the psychological aspect. And social, you could see financial status. He is not going for the job right now. He was a only breadwinner. There is a loss of job. There's a loss of role in the family. He is not independent right now. Previously, he was very independent. He's now he depends on the wife to go to the hospital. So he has lost his independency because of this serious health related suffering. And marital conflict, because he was a previous chronic alcoholic and a smoker. Right now, they were having a lot of conflicts within themselves, right? So that can also add to the social as well as the emotional part. And isolation from the friends and relatives who were drinking friends. Previously, he would have a club. He would go with them together and then booze and then come back. Right now, all of them had isolated him. So that also adds to the social pain. And spiritual. Why me? Life is unfair because 10 people in his team would have, had drinks regularly, but right now he is the only person who got cancer. So he might feel why this happened to me, why life is unfair. Is this something which is a punishment for my sins for I have drunk the whole time and this is why God is punishing me right now. And what is the purpose of my life? What is the purpose? Why should I continue my life anymore? And the fear of unknown, which is very, very common. We don't know why they have this fear. So they will have this fear, like after they pass away, after they go back, like after death, will there be more suffering? That is the fear of unknown. So these are some of the important aspects of total pain. I hope you could have understood whatever I have taught. So I would like to acknowledge Dr. M.R. Rajagopal and Dr. Sunil Kumar, because of whom I have learned more about pain, and the presentation that I have made is a lot of points from whatever I have learned from them. So thank you.
Thank you, ma'am, for the wonderful session. Anybody have any doubts on this presentation? Please ask here. Any doubts? Mamta, do you have any questions?
Ma'am, I'm confused with episodic pain and incident pain.
So, okay. So baseline pain is something which is baseline, which is always there, which is continuous and can be intermittent. But a breakthrough pain is something which happens with a high severity, high level of intensity. When the baseline pain is there, the hike happens. So there is a baseline pain which is there, and then there is a hike. Okay. All of a sudden, there is a increase in the severity, and that is termed as, because this person doesn't know that breakthrough pain is going to come. If that is an incident pain, he knows, okay, walking to the toilet might create some pain for me. That is a precipitating factor which is leading to the pain. So that is termed as incident. But when it's a breakthrough pain, usually they do not have any warning. All of a sudden, with the baseline pain, this breakthrough pain occurs. And if the baseline pain, the pain score was 3/10, when this breakthrough pain occurs, the pain score might be 7/10 or 8/10. So that is how we term breakthrough pain. I hope this is a little bit clear for you, Mamta.
Yes, ma'am.
Thank you.
Anybody have any other questions? Okay, so before moving on to the case presentation part, I would like to highlight few things. We have learned many things today regarding pain. This is one of the most important part in palliative care. Pain is a subjective symptom. We need to believe the patient words. And also, madam was saying like pain is what the patient says, hurts. So that is the another definition of pain. So whenever we have seen a patient with pain, we all nurses, most of the time, nurses will be spending more time with the patients. So whenever the patients have pain, sometimes we don't feel about their face pain. So that time, if they have pain, if they say pain, you have to believe the patient words and understand the patient's pain, and you have to treat accordingly. So this is a subjective symptom that is very, very important. So you have to believe the patient words. And also you have to do the proper assessment. In palliative care, most of the palliative care centers are running with nurses. Nurses, you have an ability to do the proper assessment. If you do the proper assessment, definitely we can plan accordingly, and the patients will get a good management. Okay, so management part is also important. You have to learn about we already learned STPQRST, how to assess pain. I don't want to explain all. Madam was already discussed with you all. You have to go through the slides, and if you have any doubts, please put that question in the WhatsApp group so that we can able to answer. Okay, so this is you have to keep it in mind always. Okay. Thank you. Then we can move on to the case presentation. Mamta Kishali will be presenting a patient story today. Mamta, so to you.
Just wait. Okay, good afternoon, all. I'm staff nurse, Sister Mamta, and my presentation is 69 years old female, and she diagnosed with carcinoma left breast cancer with lung mets. Are you hearing all?
Yes.
Sorry. And she has presenting complaints are pain in left breast and left shoulder, and tingling sensation in hand. She has also low mood, insomnia, cough, breathlessness, weakness, weight loss. History of present illness. The 69 years female had pain and a lymph node feel in her left breast 6 months ago, and then she went her doctor. Doctor advised her biopsy and further investigation, and she did biopsy. After biopsy, she diagnosed carcinoma cancer and suspect. She did CT scan. Then she suspect with lung cancer. Examination, her BP is 110 by 74 mmHg, pulse 90 per minute, and temperature ephemeral. Her SpO2 is 90% saturation, and chest air entry low in left side, abnormal sound, and severe S1 S2 sound is normal. Her abdomen is bowel sound is clear. Treatment and significant investigation. So patient is not able to take any curative treatment because she is 69 years old. But in investigation, biopsy shows moderately differentiated carcinoma, and in CT thorax shows bilateral lung parenchyma with pleural effusion noted. Psychosocial aspects. The patient is very poor and not able to take any type of treatment like symptom treatment or palliative care treatment. She is worried about her disease. Medication, she's taking tramadol 50 mg, one tablet thrice a day, and SOS tablet gabapentin 100 mg at night, tablet paracetamol 650 mg thrice a day, tablet Paranorm 1 tablet twice a day before meal, and tablet Dulcolex 1 tablet HS, tablet Terifylline 150 mg twice a day. Her main concern is pain. Discussion points about family, because we have to explain to her family about diagnosis and poor prognosis and medicine dose and what symptom will be coming in future. Thank you.
Thank you, Mamta, for the presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. So I hope this presentation is clear to everyone. So I have a small request.
Mehboob, you want to ask something? You have raised your hand. Okay, we can continue.
So, sorry. Hereafter, you have to, whenever you have a present a patient story, please include the patient's pain score. Today we have learned the pain assessment and all. So next time onwards, whenever you have present a patient story in pain, please add the pain score also. Okay, thank you.
Thank you, ma'am.
Okay, so we would like to hear from you all.
So, yeah, we would love to hear from you all regarding how you will assess pain, because Mamta had presented a case where pain is not elaborately mentioned about physical, social, because she's very new. She has just joined the course. So, obviously, that is expected. So, now I want you all to say what are the different aspects of pain that you will look into this patient. How will you assess the physical pain? Because that's a pain in the left breast and left shoulder with a tingling sensation in the hand. So I want you all to comment, put in the chat box, like how you will assess this patient's pain.
Anybody?
If anybody wants to just unmute and answer also, it's fine. Otherwise, I want the comments in the chat box.
I would like to say one thing.
Okay.
She did not mention about the economical condition of the patient, who is the earning member.
Okay. very
Okay.
good.
So you want to add that, the social
Yes.
aspect?
Yes, yes. Economical status and
Mamta?
Yes, ma'am.
Yeah. So,
Yes.
ma'am is asking what is the economic situation of this patient and who is the breadwinner of this family?
Ma'am, patient and his husband and one son. And their economical status is lower middle class.
Okay. And Sylvester has mentioned that we can use the numerical rating scale for physical
Yes,
pain
ma'am.
assessment. Yeah, that can be used. And Nayana and Shanti says pain may be 7/10. So how did you end up in that? What made you think that this patient will have a pain of 7/10?
Who, me?
No. In the comments, I can see that Sister Shanti and Sister Nayana has mentioned that pain may be 7/10. So what made you think so is what I'm asking.
Yes, ma'am. Hello.
Shanti ma'am, you wrote that 7 out of 10, the patient's pain score was 7 out
Yes,
of 10. So how did you
yeah,
write? Based on what, which,
yeah. Based on the treatment that she was getting, tramadol, already she was getting BD, and still the pain is persisting. Means already still she is having so severe pain and radiating to shoulder and also tingling sensation in the hand. So and she is also unable to sleep.
okay. So that
So what
all
is
we
our procedure?
understand, that all we understand. Then my question is, how did
Yeah.
you say about 7 out of 10?
I'll still say, madam.
Assuming.
Yeah.
So
Yes, ma'am.
from today's class, we have learned about do not assume,
Okay.
believe the patient words. Always the pain is a subjective symptom. You have to ask the patient and tell them about the pain score. If they have pain, if they say it's like, I am having pain, you have to tell the patients the pain scale, 0 to 10 scale, numerical pain scale, and ask them about what is the pain score now. So
Yes.
they have to tell.
Yes. Thank you, ma'am.
Okay, very good. Thank you for putting it in the chat so that we were able to discuss this now.
Yeah.
Because many a times we do this mistake and just assume that it can be 7 out of 10, can be 8 out of 10. And even for a person with 10 out of 10, actually, you might think based on the facial expressions that he might have only 1 out of 10. So that is why we say we should never assume, and you should go with the patient's self-report. So pain score is something that patient has to say and we shouldn't be saying. Clear?
So one question in the chat box, Pini ma'am is asking a question. We can assess the pain or we can understand the pain by the facial expression. What do you think? Others? Can we assess the pain? Can we ask the patient about his or her pain, or you can understand the pain by the facial expression?
no, we have to ask the patient.
Yes, very good.
Yes, we have to ask the patients. Sometimes the patient, if they have pain, but they will not express their pain in their face. If you ask them, definitely they will say, yes, I have severe pain.
So then
So-
we have to evaluate the physical, this one aspect, like you said, acute pain and the chronic pain. So the acute pain will show the dilatation of pupil, and the chronic pain will have some neurological affected. Yeah. So in that way, we can analyze.
Yeah. So when we come to the palliative care, we mostly use nociceptive pain, neuropathic pain, instant pain, visceral pain, breakthrough pain, that kind of words.
Yes.
So yeah.
And one interesting question from sister brother Divakar. I don't know if he's a sister or a brother, but it's a very nice question. If patient is a child, yes. So in a child, obviously we understand that assessing the pain score might be difficult, but for assessing pain in a child who is 3+ years of age, we have a finger span scale. So finger span scale is when you show to the child that if you say this much, kuti, right? The small part. If you just show this much, then it is going to be mild. If you just gap it even more, it is moderate. And if you show this, then it's going to be severe. So we cannot actually go with the actual scoring, but you can go with the finger span scale for children who are more than 3 years. And also in some patients, Wong-Beaker's faces pain rating scale is also used in the children, most commonly used in the elderly, but also in the children, when you can give the chart to them and they will mark it. If they are like around more than 2+ years, they will just circle the face and all that. So it becomes challenging for you to assess pain in children, but there are certain scales which are available. One thing that is, it's a finger span scale.
Ma'am, I have one question. If patient is not able to speak and he's unconscious, so how we?
Yeah, in that case, it is very, very difficult to assess pain. We have to go with the words of the caregiver. Like we can ask whether the baby is crying at night or how he is. Baby is actually having a good sleep or he is very irritated, the mood and all those things. No, it happens. Even for a small child, even for a neonate, we often see that, right? If the baby is very much crying and all that, we understand that he or she has some problem, and then only we take the baby to the doctor. So that is how we assess. It might be very challenging, as I said, but you have to speak to the family members. Usually in children, it's like always parents will have the whole history of how this started and all that. But every baby or even a child who is 3+ years with a serious health related suffering like cancer, with acute myeloid leukemia or acute lymphoid leukemia, whatever it is, they will actually know what is happening to them. We might feel that the baby doesn't know or the child doesn't know, but they are very, very clear about what is happening to them. So most often when you assess, you will be able to find that. And many a times I have even felt surprised when children just ask I think the other person, the other baby who was next to me in this ward went into the ICU room and then he passed away. So am I the next person to go into that room, doctor? Such questions have been asked by very young children who are 3 and 4 years old with serious health related suffering. So we always underestimate that pain is a symptom which is very, very underestimated in children. That is one thing. And also we underestimate their potential that they might not know anything. But actually they know everything.
Okay, thank you, ma'am. Sylvester is put a chat note in the management of neuropathic pain. Anyway, we have a detailed session on the management part, but the gabapentin is the good medication for neuropathic pain, but the thing is too expensive. If the patient is not affordable, we can't write this advise this medication. So that time you have to think from the baseline. You have to think about the low cost medications like tricyclic antidepressants. Tricyclic antidepressant like amitriptyline and imipramine is the best drug for controlling neuropathic pain. So that can also, you can think about it. Anyway, we have a detailed session on management part 1 and part 2.
Any more doubts or
Uh,
questions? Otherwise, we can close for
Yeah,
today's session.
Mamta, I have one question. Did the patient is getting adequate pain relief with tramadol?
No, ma'am.
No.
Ma'am, before she was taking paracetamol,
Mm.
but paracetamol is not getting relief. Then I start tramadol.
Okay. When did you start tramadol?
Ma'am, 1 week before I start tramadol. She's my patient.
Okay. So how many hours the patients get pain relief with tramadol?
Ma'am, with tramadol, she is fine. Like she's getting relief. She's getting relief.
Oh, she is getting relief with tramadol, right? That's
Yes,
good.
ma'am.
That's good. So, did you add Dalcolax also?
Yes, ma'am. I add Dalcolax tablet.
Okay, so always you have to think about that also. Whenever you have write down a weak opioid or strong opioid, you have to write down this laxatives too. Otherwise, one of the most common the side effect is constipation. So you have to think about that also. Anyway, good thing is the patient is getting good pain relief with tramadol. If the patient is not getting adequate pain relief with the tramadol, you can think about the strong opioid. You can stop the tramadol weak opioid and go for the strong opioid. Okay.
And also the other point is, as sister said, you can, if she is not getting a very good pain relief with gabapentin, then you can try amitriptyline TCAs, which are proven to have a very good pain relief in case of neuropathic pain. So you can start, you can talk to your doctor and stop gabapentin and start amitriptyline, or else you can continue gabapentin and along with that start amitriptyline on a very lower dose, amitriptyline or imipramine or nortriptyline, whatever it is. And paracetamol, make sure that, as I said, based on the weight, you're giving the dose properly. Here I could see that it's given as TID. You can make it into every 6 hourly and SOS. And metoclopramide, you can give it for a few days. It's not that you have to give metoclopramide continuously. When we are starting an opioid, for 2 to 3 days, we give it so that it prevents the nausea and vomiting, which happens initially. So you have given Perinom as BD. Okay, that's fine. So you can continue it for 3 to 4 days and then make it as SOS so that whenever she is having nausea or vomiting, he or she can take it. And Dalcolax, make sure that you are starting a dose of 10 milligrams as HS. That is the dose that is needed, minimal dose that is needed, and that is to be given along. So that's it.
And the same time, you have to address the other aspects also.
Yeah.
So you have to understand that if they have other psychosocial issues there, their physical distress will increase. So you have to make sure that the patient is better, that you have to give some attention to the other 3 aspects too. So then only we can improve the quality of life of the patients fully. Okay.
Okay, ma'am. Thank you.
Thank you, Dr. Farhaana, for the wonderful session. Thank you, Mamta, for the patient story.
Thank you,
Thank
ma'am.
you all for your participation and your interactions.